Good morning or good evening, everyone, depending on where you are joining us today. And welcome to this webinar, the UAPS SRH and FP panel webinar, monthly webinar. We are happy to have you. People are trickling in the room. Welcome to everyone. We couldn't air this webinar last month for some reasons, but we are happy to have you today. And today we have Professor Sangeeta Madhavan, who will make for us a presentation around marriage dynamics in Africa, but also how marriage dynamics and kinship support dynamics on the continent really are related to maternal mental health and using evidence from Kenya. So I hope this will be a very interesting discussions. And as usual, we ask you to ask your questions through the Q&A tab at the bottom of your screen. Feel free to add your comments or questions as we go. And looking forward for a lively discussion. So let me introduce quickly for you Professor Sangeeta. Professor Sangeeta, welcome to this webinar. It's a pleasure to have you. Professor Sangeeta is a professor and chair of African American Studies and professor of sociology at the University of Maryland in the US. And she's a family demographer working on African demography. She has made substantial contributions to the understanding of extended family systems in Africa, parenting, household dynamics, and child and adolescent well-being. She currently serves as the principal investigator of an NIH-funded R1 project that seeks to understand the interactions between marriage and kinship support and young children development in poor urban settings. And some of the work she'll be presenting here is part of that grant. Professor Sangeeta is also a prolific writer, and her work appears in many journals, including Population and Development Review, Space and Place, Social Science Research, and Journal of Marriage and Family. But I will say for me, Professor Sangeeta is a collaborator. I'm happy to work with her on this particular project. And for those who are interested and questions on marital marriage dynamics and union formalization and kinship support in Africa, Professor Sangeeta is somebody who is leading research in that field, and we'll be very happy to receive your questions or to receive follow-up email for further engagement beyond this presentation. So Professor Sangeeta will give us a presentation for about 30 minutes, and then after that we have we open the floor for her to respond to questions. We will have all the questions within, again, as I say, the Q&A tab. So please feel free to type your questions as we go. And then at the end, we will have those questions to Professor to answer. So Professor Sangeeta, welcome. You have the floor.
Thank you. I just want to make sure, can everybody see the screen and hear me?
We can.
Yes. Okay, great. First of all, I want to start by thanking Estelle and the entire UAPS panel for inviting me. This is really an honor. Actually, Estelle sort of downplayed her role in this project. She is absolutely a true collaborator, and none of this actually could happen without her involvement and the rest of APHRC and the team in Nairobi. So I just want that to be made clear. And in fact, the names you see on the slide are really just 5 people from a much, much larger team. Okay, so the other reason I think I'm really excited to be here is because, this project has been now going on for 4 years. We've been in the thick of data collection, and which I'll tell you about. And we're at the point right now where we are analyzing data and trying to get this disseminated out to as many different audiences as we can. And for me, it's really important that it gets to African researchers based on the continent, doing really important work, and also students who I want these data to be used by, it's very important to me. So I really I'm really happy to be here to connect with you to get some of our ideas out, and also look forward to your feedback and questions. Okay, so with that in mind, and also if there are any really hard questions, I'm going to give them to Estelle, who's going to be able to answer you, because she's actually a co-author on this presentation, on this paper. Okay, so the title is, Does Marriage Benefit Maternal Mental Health? New Evidence from Nairobi, Kenya. Let's see if I can, why is this not moving? Okay. All right, just to set the stage, I'm going to spend a little bit of time talking about the motivation, significance, a little bit of background, and then going into the description of the JAMO project in Nairobi, and then telling you a little bit about this concept of union formalization, which we think is one of our novel contributions of this project, and then analysis, and then share with you some results and end with some discussion. Okay, so maybe for all of you, this may be obvious, but I thought it was important to at least state, when you look at, some of you may be wondering, well, what does marriage and mental health have to do with this panel, which is about family planning and sexual and reproductive health? And this is how I think it matters. I think we know that the context of marriage and the context of relationships, there's a bidirectional effect with mental health, both negative, positive in all ways. And we also know that both of these factors, how relationships unfold, the quality, stability of marriages, relationships, and also particularly women's and mothers' maternal health, is critical for reproductive health. And whether that is sort of use of family planning services, a healthy pregnancy, antenatal care use, all of that. So I think while this is not, specifically addressing issues like family planning, I think in terms of a very, very important social context to better understand what is needed to improve reproductive health and sexual reproductive health for on the continent, I do believe that these issues are really worth looking into. Okay, and the other reason I think, and this is something I think some of you on the panel certainly are well aware of, there is now finally a welcome attention on mental health in sub-Saharan Africa, which for a long time has really been, under the radar. It has not gotten much attention. Yet we know, and these are from WHO, that 66 million women suffer from depression. 85% of them have no access to effective treatment. Women are affected at twice the rate of men. And we also know that there are some interventions that work and have produced some really, really positive effects, not just for women, but for families, for children, for the community. And so mental health is finally receiving the attention it deserves. And so we're hoping that this work actually contributes to this. This one, I think, again, may be completely obvious to all of you, but I think why we should think about mental health as reproductive health. Well, this paper from 2020 from Montagnoli and colleagues, where they clearly state prevention and management of maternal mental health diseases and minor mental conditions within the first 1,000 days timeframe should have a place in the holistic approach to women going through reproductive decisions, infertility treatment, and pregnancy. So I think that's pretty clear that if we really are serious about improving reproductive health services, mental health has to be a part of it. I just wanted to just talk a little bit about some of the recent work on this kind of mental health, reproductive health nexus. We know that from a meta-analysis that low social support has significant associations with the risk of depression, anxiety, and self-harm during pregnancy. We know from the US, from data from the Maternal Mortality Review, that nearly 1 in 9 pregnancy-related deaths had mental health conditions as the underlying cause, which was actually quite a surprise to me. And systematic review of sexual reproductive health interventions for young people in low and middle income countries, particularly in the context of humanitarian crisis, clearly shows the importance of providing psychosocial support. And lastly, this new piece from South Africa finds that adolescents who receive psychosocial support during pregnancy are less likely to be depressed, and that postpartum depression is actually associated with intimate partner violence. And I'm sure there's many more important work that's being done, but here that's just a few of them. And then when we think about marriage and health, there is actually quite a bit globally. So particularly in the global south, there is evidence that child marriage is associated with adverse reproductive health outcomes. We also know that there's evidence for the importance of partner support and family approval for positive reproductive health outcomes. And we know that these effects of marriage operate through perceived supportiveness and higher self-esteem. And then specifically from Africa, there's some work that has demonstrated the negative mental health effects of early marriage, single motherhood, and marriage itself. And lastly, some very recent work during the COVID epidemic suggests that marriage actually protects women's mental health in the context of employment loss during COVID. I think that was actually from the US. Okay. So while all this is happening, there's also been a significant transformation in marriage across the continent. And many people have written about this. But some of the big trends are that it's been moving from sort of more formal to more informal arrangements, primarily driven by the cost of getting married, which is prohibitively high. Some have said that it is moving from being really kin-driven, that is, arranged marriages, kin kind of choosing partners, to much more couple-driven, that it's really about what's going on between couples, that's where that's going on. Yet at the same time, kin and bride wealth, which I think most people on this panel are familiar with, continue to be valued. It is important to have the approval of kin, and actually bride wealth as a very formal marker of this connection continues to be valued. In general, the process of marriage, which we've known for a very, very, very long time, has become protracted, which may in part also lead to increased vulnerability of women and children. However, we went into this project sort of arguing that the current measures of marriage are inadequate to capture either the process or the role of kin, and therefore trying to understand how marriage impacts mothers' mental health is limited at best and incorrect at worst. So with that, the three questions we're trying to answer is, to what extent does union formalization, I'll explain what that is, protect maternal mental health in a low-income urban context in Africa? This is Nairobi. To what extent does relationship quality, so that would be the quality between the partners, explain these effects? And then to what extent does emotional support from kin explain these effects? And so we're trying to get at both the couple level as well as the kin role in this process. So the study that we are conducting right now, I'm sorry, my Swahili is terrible, so I'm not even going to attempt it, but essentially the JAMO project, which loosely translates to kinship, nuptiality, and child outcomes in Kenya. And the study design, so the big question, as Estelle alluded to, is to what extent does kinship support and marriage benefit mothers and children in low-income urban African settings? So this is a mixed methods longitudinal study with 6 waves of survey data collection and 3 rounds of qualitative data collection. We started with a sample of just over 1,200 mothers aged 18 to 29 with at least one child 0 to 24 months. And the first wave was actually done in 22, just after the COVID, well, sort of, as we were coming out of the COVID pandemic. And then our starting sample for the qualitative, we took 50 mothers from the survey and also included 30 biological fathers. And now actually we have some partners as well. And this is actually very, very, I won't be talking much about the qualitative, but I'm happy to answer any questions about it. And the other thing that this is not actually getting at is that even though we started with 1,200 mothers, given that this is a project on kinship, we have actually expanded the sample into about 15,000 kin of these mothers we are also following over 6 waves of data collection. So it's a pretty amazing, I mean, huge effort, and again, cannot be done without this phenomenal team at APHRC and also my colleagues here. So we've completed so far 4 waves of survey data, and we've had excellent follow-up. And we've completed 2 rounds of qualitative, and we're actually in the field now with wave 5. And then we'll do our third qualitative round in August and our final, the 6th wave later this year. And maybe this is my time to take sort of a plug for this for any of you, particularly faculty who have students who are in need of data. Please come talk to myself or Estelle, because we have lots of it. and we want it to be used. Okay. Oh, sorry. That was okay. Korogosho and Vivendani, Nairobi, Kenya. This is an estimated population of about 80,000. I don't think I have to sort of explain this to the people on this panel, but very poor housing quality, minimal sanitation, high crime, very high unemployment. Most people are engaged in the informal economy. Most people have access to mobile phones. There is a good amount of ethnic diversity in these contexts. And then, quite importantly, this is part of the Nairobi Urban Health and Demographic Surveillance Site run by the African Population and Health Research Center. So the project really benefited from the fantastic infrastructure that APHRC had put into place. Okay, so we are collecting all sorts of data, and I do not have time to go into all of it, but I'm happy to answer any questions. But the ones in red are what I'm actually going to be focusing on today. But at the mother level, we're collecting data on union formalization, which I will explain in the next slide, relationship quality, the usual household attributes like size, food security, relative wealth, etc. Mental health using a CESD 10 module, a whole load of socio-demographic information, education, employment, and actually employment, we're doing income generation, all of that. At the child level, we're looking at physical health, including nutritional status and illness incidence management, and also a very, very detailed early child development that we're following over time, cognitive, social, language development, socio-emotional, all of it. And then at the kin level, this is really, I think, also the novelty of this study, we are enumerating from the child's perspective all of the full and half siblings, grandparents, aunts and uncles on both the paternal and maternal side. So it doesn't matter if the biological parents are still in union, but we're getting all that information. We're also collecting data on non-kin or distant kin who provide support. And of course, this is all coming from the mother. Demographic attributes on all these kin, age, location, education, employment, frequency of communication, and very importantly, the types of support that they provide to the mother, financial, non-monetary, childcare, and emotional. So as I said before, in fact, I'll just show it to you in the next one. So if you look at some of our, on the starting numbers with the 1,203 mothers, they're young, and that was done quite purposefully to sort of minimize exposure to transitions. The vast majority have, primary or secondary education. The vast majority, 2/3 are unemployed, but we think this is actually a function of the fact that they had very young children at wave 1, because this number does actually change quite drastically by wave 2.
Sangeeta, sorry to
Yes.
interrupt you. Can you put that on slide mode? I think it's.
Am I not?
You can see on slide mode, but it's still small. I think it's now better now. Yeah, thank you.
I'm sorry about that. Oh, I wish you'd said that to me earlier. I'm really sorry. I hope that okay. Anyway, okay. I'm dealing with 2 screens and I ended up looking at the wrong screen. Okay. The distribution of ages for the children, it's definitely, we couldn't get as many very, very, very young infants. Birth weight is about 3 kilos. And then this is the interesting one, the surviving kin. So we started with about almost 15,000 surviving kin, mean age of about 29. Again, the vast majority has secondary primary education. Even here, 39% are unemployed, but 38% are involved in formal, and 22% in informal employment. And then this proximity. So this is, where are they in reference to the woman? The vast majority, well, actually over 50% are actually outside Nairobi. 33% are within the same house or in the two communities that we're working in. Another about 15.7% are in other places in Nairobi. Okay, so the union formalization measure. Many of you are probably quite familiar with the demographic health surveys. So on the left, this is the usual question. What is your current marital status? Are you in union? So meaning, are you married or living together as if married? Or if you're not in union, it's usually, are you divorced or separated, widowed, or never married? Now, what we said, our claim is that this is quite a very not an effective measure to actually understand process, which, as I said earlier, is something that has been protracted and is actually, and the various steps of it are actually, we feel, very important to actually understand women's vulnerability. And so through extensive qualitative interviews and cognitive interview testing, we arrived at these 7 questions. Are you living together? Have you been introduced to your current partner's family? Has the current partner been introduced to your family? Has the current partner's family started talking to your family about your dowry? Has any part of the dowry been paid? Has a wedding ceremony happened? If so, which kind? And have you gotten a marriage certificate? These steps were through extensive qualitative formative research were identified as the salient steps that women felt is the process through which a union is formalized and strengthened and legitimized. And also the role of kin here is critical, not just as a way, for social identification, but also for financial support. Because as I just said, this is a very, very difficult economic situation. And so the role of families role of kin is actually critical to actually both the stability of the union as well as the well-being of women, children, and other members. And so we came up with this measure, and just to give you a visual, this is a Sankey diagram, which basically what it's trying to demonstrate is on the left-hand side, you have those DHS categories, and the right-hand side are the UF categories. And it's kind of, I think what's the obvious thing here is that which the DHS considers to be married or living together is actually very, very, very heterogeneous, sorry. And that while you have, there's quite a significant amount who are actually living together, but have had one or both introductions. There's a smaller number who have lived together, have the introductions, and also have bride wealth negotiated, or even in some cases paid. And so this is to kind of show you that, partly that the data suggests that what we initially expected is actually playing out. That if we just went by the married or living together DHS category, we would miss this kind of variation, which we would argue is actually critical for women's well-being. And also, and in this case, what I'm going to talk about is mental health. Just to give you some numbers, this is another look to sort of looking at when we think about if you just take the people who say that they're in relationship with the biological father at wave 1, if you just break that out, that's 77%. This is the distribution of the steps that these women have taken. These don't actually sum to 100 because it's cumulative. But I think what is coming out here is that living together, obviously, living together and these introductions are by far the most common steps. Meanwhile, the bride wealth discussion seems to, that's not a negligible amount. But the actual payment of bride wealth and wedding ceremony, marriage certificate, these are much, much, much smaller. And maybe that's not all that surprising in this community where, again, financially very, very precarious conditions And to have a wedding ceremony takes a lot of resources, which people do not have. But we would argue that this key part about this introduction is actually very critical as a source of both social support as well as financial support for women and their women and their children. Relationship quality. We did not come up with this. We're using subscales used in prior studies, which measure commitment, trust, communication, and conflict resolution, and a standalone item measuring overall relationship quality. We conducted confirmatory factor analysis and did both first order and second order to confirm that they actually do measure what we think they're measuring. And we get a range from -8 to 8. The higher, the stronger, the better the quality. And just to show you that this is just kind of a confirmation that you would expect that more higher union formalization is actually, there is a correlation with better relationship quality, and that is indeed what you see. So for example, I mean, everything on the positive side is better relationship quality on the negative. And so these dark blue lines are basically where there's very little union formalization, and hence relationship quality is actually quite poor on all of these subscales. And then the emotional support from kin, we ask it through by asking her, what other types of support does this enumerated KST member provide for you? Do they give you advice when needed, assurance and comfort, companionship, friendship? And the measure is actually the number of people over the age of 8 who provide any of the above. And so we have a range of anywhere from 0 to 19 with a median of 4 and a mean of 4.6. So methods and sample size, our outcome measure is at risk for depression. Our key exposure variable is union formalization stage, which actually has been, it's been operationalized as a Gutman scaled measure, and I can explain what I mean by that in the Q&A. And then we're also looking at these mediators of relationship quality and emotional support to see to what extent they actually explain any effects we see. We're using cross-flag models to predict depression risk in subsequent wave as a function of union formalization in the previous wave, because this also allows us to test for reverse causality. And then these mediation models, as I said, to look at the extent to which relationship quality and emotional support explain these these effects. And then we include a range of controls at the mother and household level. This is somewhat of a select sample because we're looking at using just the 745 mothers who were in all 3 waves and also in the same relationship. So I should be quite upfront about that. This is not the whole sample. This is, what are, as of wave 1, as you can see, about a quarter of our sample is either moderately or severely at risk for depression. This, 25% out of, so we're talking about 400 women or so, about 350 women, that is actually a sizable number. And actually about half of that are actually severely depressed, which is something, as I explained to you in the beginning, in many of these contexts, there is no means to actually help and support these women in these conditions. Just to give you kind of, I think just to see how we're thinking about this, if you think about union formalization on the left, which is actually a continuous variable, we're looking at risk of depression, which is just it's a binary 0, 1. So there may be a sort of direct effect, or it may be working through relationship quality and emotional support from kin as indirect effects. So the results of the cross-flag with union formalization, what I think the key things here. So when you see these the straight arrows, the 0.879, 0.921, and the bottom, the same things, I mean, that is what you would expect. It's just basically saying that, if you are at higher, there's very, very strong correlation across waves. The more interesting story are these cross-flagged ones, right? So interestingly, from wave 1 to wave 2, there isn't much going on. There doesn't seem to be any lagged effect of union formalization on risk of depression wave 2, nor is there any reverse causality going the other way. However, between wave 2 and wave 3, we do see some interesting effects. So the 0.814, remember, this is an odds ratio. So this is sort of saying the more formalized a union in wave 2, the risk of depression goes down by about 20% in wave 3. And then if you are at risk for depression at wave 2, this negative 0.106 is a little bit more complicated to understand, but what it's basically saying is that it actually lowers the likelihood of progressing in your union formalization, which sort of makes sense, because if you are mentally, if you are suffering from depression, it stands to reason that the effort and the activities to actually make the union actually become more formalized are going to be less likely. So when it comes to mediation models, I think what we see here with emotional support on the left, while there is this sort of direct effect of, having more emotional support from kin does seem to lower the risk of depression, it's not really working. Union formalization is not working through emotional support, because there's no, the 0.123 is not significant. However, on the right-hand side, for relationship quality, these are strong effects. And so, in fact, it's entirely explaining this by saying that, more formalized unions lead to, excuse me, are associated with higher relationship quality, which in turn lowers the risk of depression. So relationship quality really seems to be the driving factor in trying to explain this relationship. And here we just put basically both of them in the same model, and the differences are not, it's actually pretty similar, except now when you put both of them, there also seems to be the indirect effect of emotional support seems to be coming through. However, there is no effect of this kind of double mediation of relationship quality on emotional support affecting depressive symptoms. So with that, let me just move to the summary of findings: that maternal mental health is sensitive to union formalization. The more formalized, the better the mental health. And so this may be because women feel more secure with the involvement of kin, both financially and socially. I didn't show you this, but we ran the models with the DHS categories, and we do find that our measure is actually a better predictor. There is some evidence of reverse causality that we need to be mindful of. And that the effect can be explained through improved relationship quality and more emotional support. And so it may be that kin involvement may serve to stabilize, strengthen the couple relationship, or that more formalized unions may activate more emotional support from kin. This is something that I just wanted to make you aware of. I don't think I have time for it. This is actually in a paper that just got published in Population Development Review, but I just wanted to make you aware of, since this is about reproductive health, that we're trying to show what is the timing of childbearing in this process. And I think what I just want you to take away is, in the shaded box, is to, again, sort of appreciate the heterogeneity of, so when you think about a term like premarital childbearing, it's actually there's a lot of variation in what that means, which means that this has very different, and therefore the impacts for children, for women, is going to be very different, and something that we should be paying attention to. So with that, I want to just acknowledge the much, much larger and much more fabulous team we have at the University of Maryland, all the great students who've been working on this, and of course at APHRC, all the researchers and the fantastic team without whom none of this would be possible. And closing, this has been funded by the NIH and some other awards. And thank you, and I look forward to your questions. And that's the website if anybody's interested in learning more. Thank you very much.
Thank you, Professor Sankita. Thank you for these interesting discussions. Yeah. As I mentioned, you can type your question, comment in using the Q&A tab.
Estelle, sorry, can you? Okay, the share screen is gone, right?
Yes,
There is no.
yes. Now
Okay,
we
sorry.
can see. Yeah, thank
Okay.
you.
Okay.
Yeah, yeah. Yeah, again, thank you for this presentation. Yeah. So we have one question. So please feel free to type your questions, comment. As I say, we have not activated the tab for you to be able to raise your hand and ask your question. So please feel free to ask your question through the Q&A tab. Yeah. I can also see hand being raised though. Please feel free to type your question in the comment section for Professor Sangita. But Professor Sangita, thank you so much for these findings. And what we really found interesting and why we had Professor Sangita presenting these findings to us is that we think as demographers and family demographers, we need to really increase the amount of study that we do in terms of linkages between family demography and of course health. I remember I was in a meeting recently, looking at what we've been doing as demographers on the continent, and there's still a lot of questions and comments around: are we not giving to social determinants of health the place that it deserves? And I think thinking of social determinant of health, it's really, again, as demographers, remember, is to go and reinterrogate all of those demographic events, marriage, and really see how we can really link marriage to health outcomes. So I think I'm very curious to hear people feedback. We have about 20 minutes for questions, comments. And for us, for this project, as Professor Sangita said, collaborating with APHRC, we really intending to be able to have, if possible, and if people are interested, a special issue where we discuss about marital or marriage dynamics and health on the continent. So if it's something of interest, please let us know. We can look for a proposition for a special issue. And if we have people in this group right now who are working on marriage issues, linking it to health or social determinant of health in general, please feel free to let us know what you think and what you would like to investigate on your own, and if you're interested also of course of be part of this special issue that we're thinking would be good to put out there. I can see the first question, Professor Sangita,
Michelle,
about the
Michelle,
sample. Yeah, yes,
Michelle. Sorry, and
yes,
also I would love to have any feedback from people about sort of, policy implications, and yeah, that would be great if I'm opened up. Yes,
yeah,
go ahead.
yeah. Okay, perfect, perfect. So if you have any implication also, and then remember, as Professor said, also the data set is available. We also are encouraging. I know on the chat we also have junior researchers, faculty members, but also researchers within those faculties. So if you have interest on study marriage dynamics, I can say the data set is very large, and a lot of questions that we can actually answer using the data, and even the effect of multiple partnership, multiple, for women fertility, what does it mean? For women health, what does it mean? So please feel free to reach out after this webinar. So just to go to the specific questions that I see on the chat, the first one, Professor, is really around the sample. Why did we decide to have that age group that we selected? So the 18 to 29 years old. And then the second question from Leticia, how did you measure depression and why did you use 30 biological fathers and 50 mothers for the qualitative study?
Okay, so the first one on the sample, so we decided to focus on that age group, as I said, because to try to strike this balance, because the older you go, you're going to have more, a longer sort of exposure period before the start of the study in which more of these transitions can happen. So it's going to end up, introducing all these sort of selection biases and all these other things that we're not going to be actually able to measure. And so it was an attempt to try to, in some sense, minimize that that exposure period. However, obviously, this isn't necessarily a study about adolescent marriage dynamics, and we wanted to actually, and so you have younger women, you're also going to have sort of a higher likelihood you're going to have young children. And since one of our goals is also to look at child development, it was important that we also start at a very, at a younger age. Estelle, you should talk about the CESD. How did you measure depression? Because I feel like Estelle is way more of an expert than I am on this.
Yeah, thank you, Sangeeta. There is if you're interested, there's so many tools that can be used to assess, depression risk among mothers. And then the one we use here was the CSD, which is a tool that is used for assessing perinatal mental health disorders among women. So between the 6 months and 1 to 2 years postpartum, so after delivery. So if we need more details about that, we can also share that. But what it captures really, it's not a diagnosis tool. It's really the risk of depression. So it's a series of questions that are asked to women, and then they have to scale of agree to disagreeing. They have to actually express or at least respond if they experience each of those symptom or not. So questions like, have you felt unhappy and distressed in the past 7 days? Those kinds of questions. So as I say, there's multiple tools out there, but this for us was the best fit for these particular samples. So again, just perhaps to remember, these are not diagnosis tools. These are really tools to assess the risk of depression between our population. Yeah.
Yeah.
So Sangeeta, we
Sorry,
have other comments and
there was
questions.
the
Yeah.
last, they asked
Mm.
the question about the qualitative,
Oh
mainly
yeah.
as trying to, I think the big black box for demographers and family sociologists is sort of, where are the men? I mean, because most of our data comes from women, and so we thought that, first of all, so it was really critical to sort of actually capture men's voices in this whole thing. And so we started with 50 women, and essentially they were, we needed to kind of get to the men through the women, if you like, for a number of reasons. And so 30 was the way. I mean, many of them were not partnered. And so for all those reasons, we ended up at 30, which I must say, I'm really, really amazed that our team has been able to pretty much retain all 30 men so far. I mean, in both waves of qualitative over 1 year, which I'm amazed with it. And I think we're going to have the same for the third round. So it'll be like longitudinal qualitative on men, which I think is actually very, very rare to find.
Yeah, thank you. Yeah, we have two other questions. The first one, very interesting presentation, Prof, and great to see the new approach of capturing formalization that takes into account the local context. I'm very much interested in mediation analysis approaches and the application. So my question relates to this. In the variables you adjusted for, are there any that might have been influenced by the union formalization? And then they go on to influence either of the two mediators and the outcome. If so, what implication will this have on the observed effects through the mediators?
No, great question. So yeah, I mean, the cross-lag models are, meant to, as I said, the nice thing about them is sort of you capture both these lagged effects and also because, the possibility of reverse causality, because it's not just that the more formalized a union, better mental health or whatever it is, it could also be that better mental health, so it's fully endogenous. So in terms of the mediation question, I think probably the best way I can say is the control variables, which I didn't really show you any sort of those. I have the numbers if you're interested, but is there a possibility that there is sort of bias? Probably. But the one thing I can tell you is that right now, actually, which I wish we're actually doing growth modeling of actually looking at change over time in both union formalization and mental health, which I think will help us better identify sort of at least the temporal ordering. And, it's always, you have to be careful to use that word causality, but at least give us a little bit more confidence in sort of establishing causality. But yeah, I mean, I think the point is well taken.
Okay, thank you. The next question from Ebere Chukwu Ezea. The topic is quite interesting. Marriage formalization is important, especially in Africa, because it shows that the woman is known and by extension accepted by the husband family and will be able to partake in the dividends from the
Yep.
larger family kin. I like the word dividends. Yeah. And then the next one is thank you very much for providing us an insight on this is very interesting research. How did you identify the mediator variables?
So this would be relationship quality and emotional support. So I think it comes, well, if you think of, so some of it was driven by the literature, which, there's been this tension, the way I see it, between kind of this more couple-oriented union formalization. There's some evidence that that's happening, that, moving, and I think this is global. But at the same time, the kin haven't disappeared. So if you think about like Dan Smith's work from Nigeria, and I've written on this from other places, that kin still and families still continue to be very important for exactly the reasons that the other participant gave. And so we were trying to actually see, okay, well, let's see, if which one has sort of which is sort of the bigger driver of some of these effects. And so there's literature, but also, as I told you, we did a lot of formative qualitative work on this, and Estelle can attest to this, going on for several years. And so I think from all of that data, both, and also the quality, it's so obvious that it's pretty clear that the two are sort of, I don't know if it's really a competing, but they're both there. The issue of what's going on between the partners, the couple level, and also how the role of others, both on his side and her side, to what extent, that's important. And so I think that's why we wanted to actually now formally test statistically to what extent we can actually see that in the results.
Okay, and then the next question.
And sorry,
Oh yeah,
maybe
yeah.
just to finish up, that we may see different results if we had different outcomes. So this was like maternal mental health. So it may not be, here the story is, okay, it's mostly driven by the relationship quality, but that may not be the case if we were looking at, I don't know, some child health outcome or something like that. So yeah, just that.
Yeah, thank you. Yeah. And the last questions we have, what are you seeing in terms of change in depression prevalence across the waves?
Yeah, so interestingly, the growth modeling, okay, so I didn't show you the means and stuff, but as I said, a quarter of the sample in wave one was moderately or severely depressed, reported as moderately severely depressed. What we can sort of see across these four waves is that there does seem to be a decrease in the CESD score, which is actually a good thing, because lower the score, the better the mental health. Though I want to be careful, because I think we need to do a lot more to actually, that's exactly what we're doing right now, is actually trying to look at what is happening over time. So because I think this sort of depends on where you start and the extent to which, so we've been these growth models actually try to allow you to get at sort of what's happening with the slope and accounting for the intercept. So that's exactly what we're doing. So and Estelle, please add to this, but so far, just on a purely just univariate descriptive level, the trend seems to be going downward, but I don't know if you have and this isn't a longitudinal. That's different from the kind of cross-sectional sort of work that you might be doing.
Yeah, thank you. There are two other interesting questions here on the chat. Somebody said, Mwazu Shamaki Alaji, who asks, sorry, I joined the webinar very late, but can you explain a bit more on the relationship between mental health and union formalization in a Muslim-dominated society?
Yeah.
Wow.
Okay. Yeah. Estelle, I'm going to need your help on this one. So I think this is a great question, and let me be a sort of okay. So yes, this union formalization tool we have, I think it is a very, very fair thing to critique it, to say, is it actually appropriate for, groups that are, Muslim ethnic groups, because we know that the process of getting married is actually qualitatively very different. And so I'm not sure I can actually give a better answer than that, because I don't want to suggest that somehow this is going to work for everything. And I think what the participant brought up is, he's absolutely right. And this is something that I think should be tested, should be examined, should be to what extent can we adapt this? Are there sort of some feasible modifications that could be put in to capture things that are more relevant for Muslim contexts? I think these are excellent questions, which,
Yeah. Yeah, Mazu, thank you so much for that question. So if you want to follow up, we can put you in link with the team, the research team. It will be very interesting to actually know if those patterns also work within, different contexts, because we really looked at Christian marriages here. Yeah, thank you for that question. And then the last one from Simeon, asking, I will be interested to know the link between early marriages and postpartum depression with regards to lack of job or even lack of financial support. Maybe try to identify some of the coping strategies, especially for the youth.
Yeah. I mean, Estelle, you may be better placed to respond to this, but I mean, it's a great question. And first of all, I think I would start out by asking, what is early marriage? I guess the official definition is before 18. I don't know. So yes, I mean, I think we already have work that, and I kind of alluded to it in the beginning, that early marriage does seem to have some, and you could see negative effects on mental health via everything from school disruption to, perhaps, I think some other work has talked about IPV incident. So I think all of those pathways are possible. One of the reasons, I know I went through it quickly, but the sequence analysis that I showed at the end, and that was published in PDR, is trying to sort of get us to be a little bit more thoughtful about this issue of what we name as sort of premarital, childbearing, or what is, adolescent childbearing. And that I think we're sort of suggesting that it's not all the same, and that the extent to which these formalization processes have occurred, let's say if you have two 17-year-old young women, if we would argue that where they are in that union formalization process actually matters, even if both are considered to be early marriage, early having a child, whatever. So yeah, I don't know if you want to add something to it, Estelle.
No, I think, yeah, I think it's those are very important questions. As again, I'm repeating myself, but we will be very interested to know if the people were interested in conducting or carrying out this kind of analysis, looking at old women, adult women, but also looking at adolescent women, because it's also a group that is, specific needs, and we know early marriages are still prevalent in a lot of countries despite the policies. So even as early as 15 years old. So yeah, so if it's something, Simeon, that is of high interest, please feel free to reach out to the team, and we can put you in contact. And then we can see how you perhaps can use the data also to look at adolescents specifically. So thank you for that interest.
Can I just say, Estelle, you have the slides, you also have the website, but if you go to our website for the project, all the tools are up there. So all the questionnaires are up there, the code book is up there. In fact, I'm about to update the code book. And so, my suggestion is, if anybody is interested, please start with that. Just take a look at the kinds of things we've collected, and then you can, reach out to myself or Estelle, and we can. But as I said, I'm absolutely open to, particularly students or early career researchers on the continent. I would love for these data to be used. So please don't hesitate connecting with us if you have an idea.
Thank you so much, Pro. Thank you, Sangeeta. Let's give her a round of applause. You can do that by using
Virtual.
these days we can give applause using the
It's
technology.
fine. It's fine.
Yeah,
No.
but again, I
All
know
right.
perhaps still questions, but for the interest of time, we have 5 minutes left. So I think for me, on behalf of the panel, is to appreciate you, Professor Gita. Thank you for your interest, and thank you for making it to share with us this interesting result. For the group, you know that the UAPS meeting is coming, the African, it's the ninth, yeah? Sylvia, the ninth African Population Conference. I know some of you or most of you have abstracts that have been accepted. You're preparing to go to Malawi in the next, 3 weeks time. So please register and make sure that we go to the conference to talk about all of these interesting, issues around demography in Africa. But one of the announcements that I'm asked to give you is that next month we won't have a seminar next month because most of the team on this panel will be working on the UAPS preparation of the UAPS meeting, and we will resume on the 26th of June. Yeah, on the 26th of June with a presentation from Professor Viseo Ajiwanu on 26th of June. So as usual, you have more detailed information about the topic and of course the links to register. Professor Ajiwanu, who is a Department of Demography at University of Montreal, will talk to us about the pathways to childbearing and contraceptive practices among women in Union in West Africa. So yeah, so again, as I say, thank you for your continuous participation to this webinar, and thank you, Professor. Thank you, Sankita, and yeah, and everyone have a nice day. Everyone, nice evening or nice day, depending on where you're located in the world. Okay,
Thank you
thank
so
you.
much. It was
Yeah,
a pleasure.
and
Thank you.
pleasure, and see you next time.
Bye.
Bye.
Thank you, Professor Sangeta. We appreciate you a lot. Thanks
Oh,
so much.
no. It's my honor. Thank you so much.
Yeah.
Bye-bye.
Thank
you.
you. Thanks for the brilliant moderation. We appreciate you. Yeah.
Thank you.
Thanks,
Bye.
Soho.
Bye. And
Bye-bye.
see you
Bye.
in June. In June 26th.
Yes,
Bye.
June. Yeah, we meet again. Thanks. Bye-bye, everybody.
Bye.